Good morning, everybody. Thanks for joining us in this early morning on the last day of the conference. As Bill said, we just had a few minutes to talk about our use of the ReDS vest and how we use this technology in our system. We were early adopters of this technology, and we've really tried it in many different scenarios. You're going to hear a lot of people today talking about how they used it in various modalities, and sort of my job has been appointed to say, how does it work for you? You're going to hear all these people doing different things. Where do you start with this technology? How do I make it into my center, and what do I do with it? So I'll try to give you a little bit of our experience of how we did it across various sites and try to guide you of where it may be the best place to start. So this is us. This is Moses Cone Hospital, Cone Health. We're in North Carolina. We're a 6-hospital system, about almost 1,300 beds, 12,000 employees, and we have 40 cardiologists. 2 of us are advanced heart failure docs, and we have three apps, heart failure apps, and a lot of pharmacists helping us. We also are fortunate enough to have a very large ACO. Our ACO is a next-gen ACO, about 200,000 covered lives. And the interesting thing about our patient population, although our hospitals are fairly well concentrated, our patients are spread out among various hospital systems. So you see us here, Cone Health in the middle there, and you see we're sort of surrounded by academia. Chris is over there at UNC and Rex. We have Duke, we have Wake Forest, and you see some other large systems. But we sort of take this swath in the middle of North Carolina from north to south, and there are some areas that are fairly suburban and some areas that are extremely rural and have a few resources. And this is just a nice schematic of some of our outreach and outlying hospitals and our outreach plans when we were putting together our plan. So one of the first things we did is we wanted to define how big is the problem? How much lung water are we missing? Are we doing a good job managing these patients? Is there more to benefit? Where should we focus our efforts? So we actually started at discharge. And what you'll see, bear with me for a second on these graphs. So the green zone is, as Bill pointed out, is patients who have lung water in the normal range, which is 20 to 35%. The yellow zone is this 36 to 38 sort of mid-range zone, and 39 or greater is the red zone. And if you use the technology, you'll start to see that people really start to get symptomatic when they're in the low 40s. 41, 42% is really the time when people start complaining about bendopnea, orthopnea, and things like that. So you see at the time of discharge, you see 1/3 of patients go home significantly volume overloaded. And if you add in the mildly volume overloaded, 43% of patients go home wet. And to my knowledge, and Bill probably can tell better, this is the first time that anyone's ever actually measured lung congestion. At the time of discharge, people have looked at weights and how much weight people lose in the ADHERE study. But this is really the first direct measurement of what patients look like at discharge. Then we took it to the clinic, and we found almost exactly the same numbers. 40% of people who walk into the heart failure clinic for their visit come in volume overloaded, and 1/4 of them are markedly volume overloaded. And then you can see in Frank's domain over there, you can see if a heart failure patient comes to the ER and our ER, 95% of them get admitted to the hospital. But if you really look at their lung congestion, 41% of them are markedly volume overloaded. And about 59% either have just mild volume overload and may be able to be triaged in the ER and sent home, and 32%. We have some people using it in primary care settings, and you can see home health settings as well. So we asked ourselves when we were looking at the technology is, do we really need this? You know, it's technology, it's not an inexpensive thing to add to our program. Do we really need this? And if we do need it, how are we going to use it? So we first looked around in our clinic and we said, okay, we have the technology now in our clinic. What are we going to do? So the first thing we did is we put it on 200 patients walking through the door. And we had our providers say, are they wet? Are they dry? What do you think? And the physicians and the mid-levels of the apps did really well, about 78% of the time. They said, yes, that patient is volume overloaded or not. So it's not perfect. We weren't perfect, but almost 80% of the time, we got it right. If you look at a non-trained heart failure provider, a nurse, or another provider, it's about 50% of the time. So about a flip of a coin when you're trying to assess lung congestion and trying to provide care. So, and then we looked at where are our gaps in care? Where could we do better? Where could we expand the care? There's 2 of us, heart failure physicians in our program. We're each over 15,000 RVUs each. We're working as hard as we can. How else can we serve our community? We were sending home health nurses out to patients to see those patients, and they would call us and say, I'm not really sure, as Bill would say, there's no actionable data here. And what we just say is just bring them in, let us take a look at them. So should we help those communities? Should we leave them alone? Should we say, look, we're just too busy? We were trying to build a VAD program at the time, and we wanted these referrals. We wanted to see these patients. How did we accomplish that? So we really came up with the motto that we can use this for 2 things. We can improve our diagnostics, we can improve what our providers do, and can we expand where we do it. So this is a little outreach trial we did. We had a hospital that's about 30 miles south of us in North Carolina, a very rural hospital. And they were stuck at between 25% and 28% readmission rates. They had 4 cardiologists. None of them liked heart failure, were interested in partnering to help the heart failure problem. So the home health nurses at the hospital came to us and said, how can you support us? Can you see our patients? How do we do this? And so what we ended up doing is said, okay, what we'll do is in patients who are going to be discharged from the hospital from heart failure, we will go to their house, a nurse will go to their house, place the vest on them within 2 days. If the patient is wet, then we'll put them in a diuretic protocol, and you'll treat them until they get into the green zone. Anytime within the next 3 to 6 months, the patient can call and say, hey, I feel short of breath again, and they'll go back out with the technology and measure them again. So we did this for a little over a year, and within that group of patients that we followed, over 105 patients, there was a 3% readmission rate within that population that we followed. So we took the overall readmission rate for the hospital from 26% down to 15%. There's the first time Medicare left them alone and didn't penalize them, and we were their best friends. We didn't see one of those patients in our clinic, and we managed to remotely manage their whole heart failure program, never stepping in Randolph County. So I'll just summarize some of this stuff before I move on here. So we really think it improves our diagnostic ability. We found out in our discharge, we did a single center randomized controlled trial at our site, 110 patients prior to discharge. The discharge was from the general hospitalist service or the general cardiology service. 44% of those patients went home congested. We looked at, what do you do with inpatient discharge? Inpatient triage. So a patient comes to the floor, they're edematous, for all the world they look volume overloaded, you give them a big slug of Lasix and nothing happens, right? So now you double the Lasix, you add a little metolazone, are you going down the right road, you take them for a right heart cath. We have one of our pharmacists or one of our nurses run up to the floor, put the clip on them and measure the fluid level. So we're hoping really that we can minimize the amount of invasive testing. People with COPD versus heart failure, what predominates here? Can you really help figure it out better? And then we talked a little bit about rapid disposition in the ER. Finally, we looked at our community. How do we expand the reach of our heart failure team in our community? And using the technology and letting them provide us with actionable data gives us an army of heart failure providers that we can use a much lower trained provider to give us the same data that we would get if we were seeing almost the same data that we're seeing the patients ourselves. And it's really increased our referrals and increased our value, we think, with our surrounding centers. So here's sort of the wrap up. So what lessons did we learn from our work over the past 3 or 4 years with the technology? So one size doesn't fit all. There are lots of ways which you can use this device, and you'll hear really many innovative ways today that we'd never even thought of. But start with the 1 or 2 that help fix the largest gaps in your care and create programs around them. Create people, create protocols, really make sure when somebody has a high number, who are they going to call? What are they going to do if the protocol doesn't work? Really make a protocol around that. So you can do readmissions, length of stay, a PharmD clinic. Our pharmacists use it in their clinic every patient they see. They're great at titrating meds. They know all the data, but sometimes it's hard to assess the volume status. This is the missing piece for them. And then, we use it. Our focus in our center has always been improve care, expand our reach. Can we continue a high level of care but yet spread out? And then one of the things we always say is measure the right thing, right? Patients come in, they have they have edema, they're uncomfortable. Is it venous insufficiency? What is it? Peripheral edema is uncomfortable, nobody likes it, but lung water is what puts you into the hospital. If you have lung water, we need to treat you, we need to be aggressive. This is the first way that we can directly measure your lung water. The other thing we learned is that people really like you and will send you more patients when they think you know what you're doing and you'll help them solve their problems. And this has helped us do a lot of that. And the final thing, I kind of get in trouble for this, but I'm going to say it anyway, is once you got, it's like CardioMEMS. I think if you have experience with CardioMEMS, once you got them, you got them. Once you use the technology to find the right diuretic dose, to really bring these people down into the green zone, further titrations, the need for further titrations don't go away, but go down markedly. So getting these patients to that baseline has really been important for us. So I'll wrap up and make way for the next talk. Here's our team. Everybody looks really skinny on our slides, so everybody's skinny in North Carolina, so thanks for your time.